Bruce, thank you. Hello, everyone. I'm going to be talking about work not that we conduct here in the clinical service, but this is a couple of sort of projects of early intervention, early and earlier intervention, as I've called it in my sort of title. But these are collaborations with a senior speech and language therapist, Vicky Slonims, who's at the Evelina at St Thomas's. Also involve Andrew Pickles here, who's a very senior sort of statistician. So I think it's quite a nice example of how different parts of sort of KHP can sort of function together. So this is a recent graphic from a sort of paper, and this is just showing you the year of publication of different trials, and this is the sample size of the different trials. So if you compare the autism field to other areas of child psychiatry, I mean, you know, one phrase conclusion is that we hadn't until recently been doing a very good job. So I used to give talks some sort of 10 years ago, and I'd be pretty confident that I could almost hold up the number of fingers for the number of randomized control trials that had been done in early intervention in autism, and many of those were really rather small. That's obviously changed, and I think we are getting a much better idea about early intervention. I'm focusing on early interventions that are trying to improve the core symptomatology of autism, so trying to improve social communication outcomes in young children on the autism spectrum. I'm going to focus on two of the studies that I've been involved in. This is the first. It's called the Pact Trial. It's obviously a large collaborative group with a centre here in London, led by Jonathan Green's group in Manchester, but also colleagues in Newcastle. This is the one bit of sort of a set of slides about the treatment sort of mechanism. So this is a parent-mediated treatment. I won't go into detail about the treatment, but essentially therapists work with parents. They get parents to capture video material of themselves playing and interacting with their child, and then they use a fairly non-directive technique of helping parents to notice, to comment, and to listen and learn about the things they're seeing in themselves, the things they're seeing in their child, and over time are able to attune parents to notice things in themselves, to notice things in their child that we think lead to better and more successful interaction. So one of the things about parenting a young child with autism is that the social communication behaviour you get off that child is different from in a typically developing child, and may actually have an impact on your parenting. So you're getting fewer signals, the signals are weaker. What is almost natural to do is to start going back and doing more and taking over and actually initiating more interactions, as we sort of say, taking over the sort of field of sort of play, and that then may have an impact on the child in a negative direction that actually means it's less likely the child will initiate these interactions. So there's a piece of work to be done by the therapists in terms of helping the parents to notice things in their child, so weak and sort of fleeting signals of communication, and then think about how they respond to them over time, and then improving things like parental responsiveness and parental synchrony. That may actually have an impact on the child in terms of drawing out, bringing out the child's communication abilities and sort of desire and motivation to have social interactions. And that could have an impact on their interaction with other people. Essentially, lots of this approach is drawn from what we know about typical infant development. So it isn't that autism's clinical scientists have gone away and developed mechanisms for how social communication emerges. We already knew that from work in the 1960s, 70s and 80s in infant developmental psychology. So this was our first trial, the first multi-site trial that we ran. It started in about 2004, I think. So it was, at the time, the largest RCT that had been run. It's a group of children with core autism. They had to meet quite stringent inclusion criteria. I'll show you some of their characteristics later on. We had followed good trial design with a pre-specified primary outcome. We're very careful about about having outcomes rated blind, etc., etc. So essentially, there are these Pact fortnightly therapy sessions between the therapist and the parent, and treatment as usual. There's a midpoint assessment because we are a group who are interested in understanding mechanisms. There are monthly booster sessions, and then there's an endpoint, essentially 1 year after treatment started. So I'm showing you the secondary outcomes first. These are all taken from parent-child interaction, so essentially play, and we have various coding schemes. This is coding parental synchrony. So the mechanistic part of a study like this is you have to be able to demonstrate that you can change the thing you're doing, what we call the proximal treatment target. Therapists are training parents to be more synchronous. So we're interested mechanistically in whether or not parents are more synchronous, and then we're sort of interested in whether that actually affects the child behaviour in interacting with their parent. These are the secondary outcomes, not the primary. Essentially, the Pact is in green, and the treatment as usual is in red. These are the individual plots and box plots. I won't give any statistics, but there's a really quite large treatment effect by that 7-month midpoint, and that's essentially maintained in favour of the Pact treatment. So this is good. Therapists are training, tutoring parents to be more synchronous, and they are. Are the children changing their behaviour in interactions with their parents? Yes, they are. So the Pact group here, at a group level, is clearly doing better at a group level than the treatment as usual group, and that's broadly maintained at the 13-month endpoint. Just to say, in neuroscience, which I also do work in, this way of always showing individual plots as well as group sort of means has become the absolute standard. Some journals will not allow you to have bar charts that don't have individual data points, and you can see it's actually beautiful in a treatment trial because you can see that some parents and children are not benefiting at all, but these are group effects that we're reporting. Then this is the primary outcome. So here the story is somewhat sort of different. We used the primary outcome, it's the observational diagnostic assessment. We modified the scoring with agreement with Kathy Lord, the originator of the sort of ADOS. Here, at endpoint, 13 months after treatment begun, both groups have actually got a reduced score, but they don't differ from each other. So that's a non-significant primary sort of outcome. Here's the sort of model of us trying to make sense of this, what was at the time initially disappointing sort of findings. So, you know, clearly something about the treatment is working. We're changing parents. Children are changing at a group level in their interactions with their parents, but we're not reducing autism severity, at least on this measure. And then we have this sort of notion that really what we're looking is, why is the treatment effect attenuating, both across the measures that we use, and these are different measures, and also across the context. Parents interacting with their child, the child interacting back with the parent who's been in the treatment with the therapist, the child interacting in the ADOS, and then we used a measure of adaptive functioning in school. So there's the very large effect size, as Stephen was pointing out, an effect size in a treatment trial of over 1, you're pretty happy with, and then it attenuates. We actually more recently went and did a 6-year follow-up of this group. So those are the findings I've shown you 6 years after treatment end. We went back and saw them again, and here in the same order. Here what we find is 6 years after treatment end, there's no continued improvement in parental synchrony. But there is, overall, an improvement in child initiations in a parent-child interaction, and there is also overall an improvement in autism severity. So in that, and this is a range of outcomes broadly in favour, not all of these are blinded, of the Pact sort of group. So it's quite unusual in child psychiatry to be showing long-term benefits from a time-limited psychological therapy, but we think that we've sort of shown this, and we think it probably will lead to some changes when the NICE guidelines are sort of revised. Then we're doing a number of things, including, actually interestingly, a new Pact generalised, working in schools as well as homes. But I'm going to tell you about autism in infancy. So essentially, what we do as a group, this is a large program of work we've been running for 15 years. It's run by myself and Mark Johnson, who's an infant scientist who was at Birkbeck but now is head of department in Cambridge, the psychology department. It's the British study of autism symptoms, and we run this study because essentially somewhere between 1 in 10 and 1 in 20 children have an older brother or sister with a diagnosis of autism, will go on to have autism themselves. And it means that we can do a range of experimental sort of studies using EEG, eye tracking, and lots of behavioural sort of measures, looking at the early emergence of autism. Well, we ran a trial with sort of joining up the basis group with Jonathan's group from the Pact sort of study with Vicky. We did a different, but broadly sort of similar, parent-mediated, video-aided, home-based intervention. This is starting at 10 months of age. So these are preemptive interventions. These kids are not showing emergent signs of autism at 10 months of age. We randomise regardless of child behaviour. It's based on genetic or familial risk. 4 months treatment weekly for 12 or 13 sessions. At endpoint, and it's quite interesting running intervention studies that have endpoints as early as 14 months of age, but we are. And we find some differences in caregiver sensitivity, so we're training parents to be more sensitive, and they are, and we find marginal differences on a few child measures in the direction we might have expected. We then follow those children up at 2 and at 3, and here, again, the same measures. This is parent responsiveness. It's a bit of a complex story, but essentially what we find is we do find that therapy starts, 20 months after therapy starts, 30 months after therapy starts, that we do find, at least up until the age of 2 years, we do find improvements in parental responsiveness. In the children, we do find improvements at a group level. I haven't got individual plots here in terms of child initiations or attentiveness, and we do find using, this is an infant version in essence of the ADOS, and here's the ADOS at 2 and at 3, that we do find, again, these are pretty marginal, but it's a small trial with an N of 54. We do find improvements in, at a group level in reduced traits of autism, we call it, because of course not all these children are in the clinical range. In fact, many of these children are typically developing, but it is a parenting intervention that's drawn from the literature on, for example, parents with low SES and other risk behaviours, so we don't think it's going to be harming parents. I've nearly sort of finished. So that's the first RCT that's reporting behavioural outcomes through to the age of 3 that started in infancy. There's another group who have reported some neurocognitive outcomes, and we think their behavioural paper is coming soon. That's a group from Seattle. So certainly, it's sort of proof of concept sort of study. So the question partly was this acceptable to parents? Could we run a preemptive trial? Would it indicate that some of the things we would expect from our work with diagnosed children, like potentially reducing autism traits, in the group as a whole would be the case? And it looks like it might be. Of course, it would be a very difficult study to run in a large sort of trial, because, of course, only something like 20% of these children would go on to have autism anyway. So you'd be sort of wanting to think of the balance between sort of ameliorating some of the presentation in the children whose pathway is on the way to developing autism versus making, you know, perhaps positive benefits in terms of parent-child interaction overall, and we hope that will be something that will be seen as positive rather than being at risk of any harm. Then this is a letter that was in The Guardian, this is the online version, after our Pact follow-up trial, the Pact 711 as we call it, so that's 6 years after sort of treatment. And one of the interesting things about sort of working in this sort of area is, of course, there was a long time that we couldn't do very much about thinking how are parents behaving with their child with autism, because of the history of this, you know, Bruno Bettelheim and other people talking about psychogenic causes of autism. And it's actually, even in the group I work with, you know, we've had long discussions going back at least 15 years about how much can we measure parental personality, other things that we think might influence whether this is a good treatment, or how different parents might respond more or less well to parent-mediated interventions because they themselves, for example, might have broader autism phenotype traits. that's a live discussion that we've had to embrace because we're in the business of parent-mediated interventions. But this parent, who's a mother of 2 children, says, and this was partly the phrase that was used in the sort of media because one of the therapists in the press conference was asked about, was this like being super parent? And she said yes, or someone introduced the sort of phrase, but the mother says, I've gone from refrigerator mother to super parent. So thanks very much.